In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 1 to 6, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. You hear a trainee doctor receiving feedback from a senior. Now read the question.
So how do you think that went?
I think it went okay, but I think I made a mistake with the number of compressions.
Unfortunately, that's right. You gave 20 compressions when ideally it would be 30. You also need to make sure that the seal over the mouth is tight before you do the head tilt and chin lift.
Thank you.
It's okay. I mean, you have your ARCP coming up, and I just want to make sure that you pass it the first time. Is there anything else within advanced life support that you'd like to go over?
If at all possible, I'd really appreciate it if we could look over the handover part again.
Sure. So in this scenario, when the critical care team arrives, you would give them a professional handover using the IS-bar framework. For example, I found this collapsed patient on the ward, so I decided to investigate as I was passing by. So the situation is, I was walking by a collapsed patient. The background is, I don't have any background on this patient. It is not under my care. I work in this hospital, but not on this ward, so I can't give you any past medical history. My assessment of this patient is, I did a trapezium squeeze. There was no response. I checked his mouth for any food boluses or dentures. There were none. He was still unresponsive. I did a head chill chin lift for 10 seconds for the rise and fall of the chest.
Now look at question 2. You hear a consultation between a GP and a patient. Now read the question.
I've come in because I've got this booming headache and it's driving me up the wall. I'm just hoping there's something you can do.
All right, did this start today or is this an ongoing thing?
No, it's happened at least the last couple of weeks now. You know, obviously I had that heart attack 2 months ago. It might be related to that, I'm not too sure. But yeah, it's been the last couple of weeks.
All right, and would you say it's come on gradually or all of a sudden? Did you kind of wake up with it one day or was it kind of, it was getting worse? How would you describe sort of the onset of the headaches?
Do you know what? It felt all of a sudden, but it has been getting worse. And this is not my first time in the GP. Do you know what? I might set up camp here. I've been in at least a couple of times in the last couple of weeks now.
All right then. Yeah, I know. So last time you were here, you mentioned that you were getting dizziness. Is that still a problem for you?
Yeah, I'm still getting dizziness. I'm still dizzy from time to time. Do you know what? It's even affecting my sleep. I'm tossing and turning, and it's booming. I just can't get rid of it.
Okay, and when did this the dizziness start?
Around the same time as the headache.
Now look at question 3. You hear a podiatrist discussing multidisciplinary care. Now read the question.
As a podiatrist, working alongside other healthcare professionals is great and absolutely necessary. We work very closely with other healthcare professionals such as physiotherapists, osteopaths, orthopaedic surgeons and GPs, to name just a few. we all kind of help each other, and sometimes the problems overlap slightly. For example, somebody could be presenting with a problem that needs both podiatry and physiotherapy, or sometimes I'll need to refer my patients back to their GP in order to get things like antibiotics, or just for a referral on to somebody else, possibly within the NHS. So yeah, we work very closely with a lot of other healthcare professionals.
Now look at question 4. You hear 2 nurses discussing malaria. Now read the question.
The practice manager's just approved my leave. It just got approved, so guess who's going on holiday?
Judging by your smile, I'd say you. Anywhere nice?
Haiti. Although I've no idea what to do about the malaria endemic. Do you know much about malaria?
Actually, I saw an article about it the other day. Where did I put it? Oh, here it is. So it says, malaria is a major disease affecting hundreds of millions of people throughout the world. It's been around for thousands and thousands of years, and it's mainly found in tropical countries. The disease is transmitted by mosquitoes, and it's usually the female mosquito that bites humans. It's part of the mating process for the parasites, and their bite injects parasites into the circulation of the host that causes the disease.
Yikes.
Absolutely yikes. The parasites travel in the blood, first to the liver where they mature, and you wouldn't even notice it because there are no symptoms for around 7 to 18 days. Then the symptoms start to develop.
What are the symptoms?
It says the symptoms include high temperature, fever, sweats, chills, headaches and vomiting. And of course, you know malaria is fatal, right?
What? There are vaccines though.
True. The article recommends taking anti-malarials at the right dosage and finishing the course before you go, plus a consultation with your GP is standard.
I'm starting to have second thoughts.
Now look at question 5. You hear a vet discussing a new cure. Now read the question.
I wanted to discuss leptospirosis, or Weil's disease, in dogs. Canine leptospirosis, or lepto, can be asymptomatic, making it difficult to detect. However, when symptoms do occur, they include fever, vomiting, loss of appetite, and lethargy. It's not a new disease. It is actually quite ancient, but is being detected more frequently due to advancements in technology and improvements in diagnostic skills. Lepto is zoonotic, which means humans can contract it through coming into contact with the urine of an infected dog. If anyone in your household becomes unwell during this period, e.g. developing flu-like symptoms, they should see a doctor swiftly. There is a vaccine for lepto, but not all vets recommend it. It could be scaremongering. People think that there is an epidemic, but it could be that we're just detecting it more frequently, as previously mentioned. There are 20 serovars of the Leptospira bacteria, which means it's hard to know which strain is actually affecting the dog, and therefore there is a fairly high percentage of the vaccine being ineffective. Some also argue that the vaccine is made from killed bacteria, which won't in itself create a response from the immune system to make antibodies. So a strong adjuvant is added to elicit a response. This can carry a greater risk of adverse side effects, especially in animals that are older. There is a cure, but making sure your animal has a healthy immune system and lifestyle may mean that a vaccine might not be necessary.
Now look at question 6. You'll hear a pharmacist discussing a new drug. Now read the question.
So I'd like to suggest that we try on oxalin sodium. This is a new variant on a tried and tested drug that was approved by the FDA at the beginning of 2018. It is a narrow-spectrum beta-lactam antibiotic of the penicillin class developed by Beecham. It's used to fight bacteria in your body and in turn can treat many types of infections such as what you're currently experiencing, a staph infection. Or to be slightly more technical, oxalin sodium is the sodium salt form of oxalin. Oxalin binds the penicillin-binding proteins in the bacterial cell wall. I don't want to confuse you any further. Take the medication provided and the site should reduce in swelling and redness fairly swiftly and heal up nicely. If you do develop a fever or any other symptoms, please do come back and see us or seek another appointment with your GP.
Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 7 to 18, choose an answer, A, B, or C, which you think best fits according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. You hear a general practitioner called Elizabeth Walker giving a presentation on child health and well-being. You now have 90 seconds to read questions 7 to 12.
Hello, my name is Dr. Elizabeth Walker, a general practitioner who specializes in child health and well-being. The topic I'm here to present today concerns vaccinations and the risks children face in their immediate and long-term future should their parents choose not to vaccinate them. Vaccination rates should be at 95% according to the World Health Organization, which would allow for herd immunity, whereby a disease will not be able to spread amongst a population. However, in the UK in recent years, vaccination levels have fallen below the recommended WHO guidelines. Although Scotland, Wales, and Northern Ireland achieved the WHO guidelines as of 2016, the national rates in the UK stood at 92%, a good 3% below the WHO guidelines. In fact, in urban areas with high deprivation, that level can fall to as low as 80%. This is a worryingly low statistic and creates a high risk of outbreaks of serious childhood diseases. However, vaccination rates have been steadily improving since the year 2010 due to the restructuring of the health visitor system. Health visitor numbers throughout the years 2010 through 2015 increased by 49%. With average health visitor caseloads falling from 400 to 280 children. This made it easier for families to receive sound medical advice and thus be better educated on the benefits of having their children vaccinated. However, the increase in rates in these years has been negated by a loss of funding in the last 2 years. This has led to a slight reduction in vaccination rates. The reduction in vaccination rates in recent years can be supported by statistics from the years 2016 through 2017. There are several vaccines a child requires in the UK up to the ages of 14, and adults over the age of 65 also require certain vaccinations. A vaccine should not be administered to a child below the age of 8 weeks, as the vaccination will not work as effectively. In the years 2016 to 2017, 4 of the 6 main routine vaccinations were administered in a smaller amount than the year before. It is the 3rd year in a row that the likes of the measles and mumps vaccine have declined in their administration rate. Although the decline was only 0.2%, this is still a trend which the UK government would see reversed. The benefits of vaccines far outweigh the very minor risks. Statistics from 2006 highlight the benefits in no uncertain light. Take the measles virus, for example, which was responsible in the 20th century for an average of 500,000 annual cases. In 2006, when vaccinations were administered at a 92% mark, that rate dropped to just 55 annual cases, a 99.9% decrease. A second example that can be used is the disease diphtheria. Diphtheria is an extremely dangerous disease and once killed 15,000 children in 1 year in the USA. The average number of diphtheria cases in the 20th century in the UK was 175,000. In 2006, not a single case of diphtheria was reported all year. That is a significant piece of evidence to use in favor of vaccinations being administered to all. Side effects are uncommon, but even when they do occur, their impacts are often short-lived. The following side effects are listed on the NHS website as common: injection site reactions, mild fever, shivering, fatigue, headache, and muscle and joint pain. These usually last only a few hours, but could extend to a period of a few weeks. A more serious side effect is an anaphylactic reaction, an allergic reaction to the vaccination, which can be life-threatening. In spite of this, such a side effect only occurs in 1 in every million vaccination, and are usually easily treated and overcome. Ultimately, the benefits of vaccinations far outweigh the negatives, and the effective immunization against the likes of measles and diphtheria attests to the success of vaccination.
Now look at Extract 2. Extract 2. You hear a doctor called Shirley Massey giving a talk on strokes and their aftermath. You now have 90 seconds to read questions.
My name is Dr. Shirley Massey, and I'm a general practitioner specializing in strokes and stroke aftermath. My topic today will be about strokes and the impact it has on the UK population. A stroke is a very serious medical condition that occurs when blood supply to part of the brain is cut off. There are over 100,000 strokes every year in the UK, which adds up to 1 stroke every 5 minutes. Strokes are often fatal. There are approximately 32,000 stroke-related deaths in the UK every year, and although that figure is down 49% from 15 years ago, there is a worrying trend emerging whereby more first-time strokes are occurring in middle-aged adults. 38% of all strokes are occurring in adults between the ages of 40 and 69, whilst the average age of a person suffering a stroke is now 68 in males and 73 in females, both an average of 3 years earlier than in 2007. This is a deeply disturbing pattern to have emerging. Although strokes are caused when blood flow to the brain is cut off, new data has emerged that suggests the chances of stroke increase due to high blood pressure, obesity, and smoking. An unhealthy lifestyle, whilst it can increase significantly the chances of a stroke, is also a relatively easy issue to fix. Promoting healthy eating and an active routine can ultimately have a positive impact on the long term and could lead to stroke avoidance. Stroke is the 4th highest killer of people in the UK, and there are 2 main types of strokes. The first is ischemic strokes, accounts for 85% of all strokes in the UK. This is caused by blockages that prevent blood reaching the brain, and the impact of this means that brain cells can be severely damaged. The second major type of stroke is a hemorrhagic stroke, which occurs when a blood vessel bursts within or on the surface of the brain. Hemorrhagic strokes are considered far more dangerous than ischemic and 10 to 15% of hemorrhagic sufferers die before reaching the hospital. Furthermore, hemorrhagic stroke sufferers have a far higher mortality rate 3 months after the event. Although stroke is largely associated with old people, there are certain statistics to keep in mind. You are more likely to suffer a stroke if you have suffered one before. Around 1 in 4 stroke survivors will experience another stroke within 5 years. Whilst of these people who have had a stroke, around 25% will have experienced one before. Moreover, although a stroke is most common over the age of 55, it can affect people of all ages. In the UK, there are over 400 child strokes every year, of which 50% are usually a form of hemorrhagic stroke, caused by a bleed on the brain. The likelihood of suffering a stroke as a child is 6 times as high as normal in the aftermath of a cold or a flu, which increase the likelihood of a blood clot forming. For a child who has had none or only some of their routine vaccinations, the chance of suffering a stroke is 8 times higher than those children who have had all their routine vaccinations.